Hi, everyone. Welcome to Pediatric Grand Rounds. I'm going to start with our land acknowledgement. We'd like to acknowledge the Ramaytush Ohlone people who are the traditional custodians of this land. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place, the land that UCSF sits upon, their home. We're proud to continue their tradition of coming together and growing as a community. We thank the Ramaytush Ohlone community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. And I'd like to now invite our Vice Chair for Education, Dr. Sandrine Van Schaik, to introduce our speaker today.
Welcome, everybody. I think there's a curse on this particular Grand Rounds. The last time that we were going to have it, it was canceled because of a strike. And now we apparently have a tsunami coming, although some people say the tsunami warning has been called off. Anyway, if we stop halfway, it's because we're moving to higher grounds around here, but hopefully we will make it through this. And for those of you who are on Zoom, I hope you're somewhere safe and dry. This will also be recorded so that people can watch it later. Our speaker for today is someone that I've known for as long as I've been at UCSF, I believe, and has given a form of this talk before. And it's actually such an important talk that we've told him you have to come back, maybe not every year, but certainly every 2 years or so to remind us of the importance of this work that he's doing on sleep and clinicians. I'm going to tell you a little bit more about our speaker, Dr. Glenn Rosenbluth, who is a clinical professor of pediatrics, specializing in caring for children with medical complexity. He works on the pediatric hospitalist team at BCH San Francisco, here at Mission Bay, where he cares for hospitalized children with a wide range of conditions, but he's also the general pediatrician for the UCSF Cross Bay Craniofacial Center. He served for 14 years as Associate Program Director for the UCSF Pediatric Residency Program Director, but we also should say he served twice or maybe even 3 times as Interim Residency Program Director. And then when we recruited a new director and he said no, I was like, why not? You already know how to do it. But that's because by that time he was already doing a lot of important work on the interface between medical education and patient safety, and particularly a leadership role in the NIH-funded IPATH study that really looked at how can better handoffs prevent medical errors and other adverse events through a communication building. And during that work, he became very interested in sleep and duty hours, and also expanded his IPASS work further to think about patient safety in the setting of patient and family-centered rounds, and that is expanding now further to think about family-centered rounds in languages other than English. He's also a co-investigator with Dr. Naomi Bardak on the Family Input for Quality and Safety study, which uses a mobile technology approach to allow English and Spanish-speaking patients and families to report safety and quality concerns when they're hospitalized. And he's the director of Quality and Safety Program for the UCSF Office of Graduate Medical Education. And he, in that work, he's really engaging residents and fellows in hospital-wide quality and safety initiatives. And as I told you, I've known him for a very, very long time. He was a chief resident when I came here for fellowship. Before that, he was in New York, where he did his medical school training. And we're just really pleased that he's decided to stay on the West Coast. That might change after today, but he's here today to talk about sleep, work hours, and physician performance.
Thanks, Sandrine, for that great introduction, and thanks everyone who's here, and special thanks to all of you who are watching on Zoom and making the time in your day. And I hope everyone's families and loved ones are safe. I tell people in the hospital is actually exactly where I want to be when an earthquake happens. This is far and away the safest building in the city based on the building requirements. So Sandrine talked a lot about my work. I think of my work, the through line is the interface of GME and patient safety? Or put another way, how do we make sure that the hospital is a safe place to learn? And so thinking at it from that direction, I got kind of engaged in sleep, work hours. I guess I also want to start before I even dig in, and this will come up. Nobody wants to work 80 hours a week. Nobody wants to work 34 hours straight, or some of us did our training. My intern year was the last year when you could have post-call continuity clinic. So you worked that 30-hour shift and then still had to go to continuity clinic. And I think over time, there's been a move away from it. And I'll come back to this, but I want to acknowledge that for the most part, we all chose a service profession, and maybe it shouldn't be quite this hard, thinking about the hours we put in. So I'm going to talk about some of the impact of sleep deprivation, knowing that it's hard and we would like to be getting sleep. And I've added more in on what we can do about it, alternative models. And I hope there'll be enough time for some good questions and discussions about it. With that said, I also want to acknowledge that the talk is sleep, work hours, and physician performance. And I realized I should have just changed it in sleep, work hours, and human performance, because it's not specific to doctors and it's not specific to healthcare providers, APPs, nurses, pharmacists, but also just people functioning out in the world. I have no specific disclosures related to this talk, nothing off label. We'll just skip the video. Basically what it is physician residents talking about the fact that they're completely sleep deprived. And there's like examples of like falling asleep on rounds and falling asleep in conferences. And one of the residents talks about actually falling asleep at red lights. Another talks about having the little ammonium vial, so that when her head drips down, she smells the ammonia and it like wakes her back up. Some really just, but these were all interviews with people at Johns Hopkins. And I don't want to single out Johns Hopkins because I think we're no different. It's just the way things were at the time. So I'm going to talk a little bit about basic sleep physiology, not very much, and then review the impact of sleep deprivation on physician performance. And again, most of the data I'm going to show is from physicians, but it's human data. And we'll talk about contextual factors as well as cognitive and procedural impacts. And then we'll talk about some interventions, which can either reduce sleep deprivation overall or at least mitigate the impact of sleep deprivation on the way we function. And I'm totally fine if people want to interrupt me and ask questions along the way. I can't really see this half, but don't hesitate to shout out if you have a question or comment. So again,
the tsunami warning got canceled.
The tsunami warning has been canceled, thank goodness. Okay, so hoping that everyone is safe from the earthquake part of it, and thank goodness no tsunami. So why is this important now? Maybe not specifically now, but in general, I guess I want to acknowledge that most of us actually have very limited control of our schedules, right? Especially the residents and fellows, right? You sign on and it's technically in your contract and you've had those conversations, but you don't really get to choose when you work and when you don't work. For those in the room, I see that lunch is being delivered, so don't hesitate to get up and get yourself some food. So people don't really have control over their schedules, and that's really hard, right? And that's different than a lot of other fields where people may have, certainly people with graduate degrees may have more independence in how they choose to work when they choose to work. You know, we're no strangers to working long shifts and many hours per week. But again, especially people transitioning from being a medical student into residency, it's really rough when you suddenly don't have any choice. And those hours, they're not hours that you can say, you know what, I'm done. This is like not good for me. I'm just going to step away. We will get back to that, right? Being able to step away. And then I think it's important to acknowledge that we all experience interrupted sleep. So even if you get sleep in the hospital, it's interrupted. And most people have at least something that interrupts their sleep at home, whether it's caring for children, whether it's caring for adult family members who live with you, whether it's people who live on the East Coast that forget that you can't always put your phone on silent mode and just choose to call you at 4 a.m, right? So we all experience interrupted sleep in a lot of ways. And so we're going to also talk about strategies, again, to minimize this impact by optimizing sleep, dealing with fatigue, and importantly, asking for help. So I'm going to just briefly hit some highlights of sleep physiology with the caveat that I didn't do a fellowship in sleep medicine. I'm sure there's a pulmonologist or a neurologist or someone who can correct me on some of this. Please don't hesitate to do so. But two big factors at play, right? One is our circadian rhythms. That's the timing of sleep, independent of the amount of sleep. There are certain times of the day where we naturally feel more awake and certain times of the day where we naturally feel more asleep. And that also is associated with hormone secretion at different times of day, right? Anyone who's ever tried to do the ACTH stim test and the growth hormone, more importantly, the growth hormone stim tests, right? You know, there's diurnal variation and then temperature fluctuation, right? Anyone who's worked a night shift and around like 3 or 4 in the morning when you go looking for those warm blankets in the little oven and you try to, you know, put extra layers on, right? That's real. That's not just in your head. That's real. And then there's the sleep homeostat, which is like how long you've been awake, how much sleep you need, how tired you are. And these things come together. So on the red line, which is the sort of sleep homeostat or sleep drive, what you see is somebody waking up at 7 a.m. and as the day goes on until evening, they get more and more tired. This is increased sleep drive. And then they go to sleep at, let's say, 11 o'clock at night, and the sleep drive goes down. And then starting at 7, the next day, their sleep drive increases. But on this, they're taking a night shift, right? And staying awake overnight. So that sleep drive just continues and continues until they go back to sleep. You get this additional pressure to sleep. And this is overlaid on the circadian rhythms, which is the drive to be awake, drive to be asleep. This very natural, after 7 a.m., your body pulls you a little bit more awake. And sometime in the afternoon, your body starts to pull you more asleep. And this bottoming out, again, at like 3 or 4 in the morning, anyone who's worked a night shift has that feeling like around 4 a.m. And you're like, God, if I can just make it to 5, I'll be okay. I know I'll be okay. But right now I'm not okay. And that's when you sort of bottomed out, but that drive to be awake hasn't kicked in yet, right? So that, again, it's biologic. It's not just that you're more tired than you've ever been. It's you're more tired than you've ever been, and that drive to be awake hasn't kicked in yet. So the other thing just to mention is sleep inertia. And that's the idea that humans who are asleep prefer to stay asleep. And so when we get a pager or a cell phone that arouse us, our body may not be completely awake. And I think many people have had that experience of answering a cell phone call or responding to a text and not actually being fully awake and cognizant. So there's a couple of levels to it. One is just being a little bit more snarky or irritable that you wouldn't otherwise do if you had your cognitive wits about you. And the other is maybe just like forgetting altogether that you had that conversation or you sent that message. And I certainly remember times early in my career when I did that. And I'll just put out there, I think I have a slide on this, an acknowledgement with humility. I do very few night shifts at this point because I'm just not good at them. My body is not wired to be able to do them, and tremendous respect for those who really can do sequential nights. We have many people in my division who are almost pure nocturnists. It's a tough job. So that's all I'm going to say about sleep physiology. A little bit about the impact of sleep deprivation on performance. And again, this should just say human performance, because I don't think anyone in the room is a superhero or an X-Men or has magical powers of any kind. If you do, feel free to say, none of this data applies to me. I'm superhuman. But if these data do apply to you, then let's sort of take it for what it is. So in the sleep studies, when we test human performance, there's usually psychometric testing that we do. So this is one example called the performance vigilance test, where you're looking at a screen, and then what will happen is a timer will start in milliseconds, and you have to tap the screen as soon as you see the timer. And it's like looking, okay, in this case, it took 318 milliseconds for the person to see it turned on and tap it, right? So that's one measure of how attentive you are and how quick your reactions are. Another example called the digit symbol substitution test, which I also think of as ordering TPN. You sort of have to here's the 2, put this here. Here's the 9, put this here, right? It's a brain exercise. And how many mistakes do you make? People in the room like that. I appreciate that. So how do we use this data in practice? So studies of residents working. This is an example of residents in the PICU. This is from Boston Children's. looking at psychometric performance over 4 weeks working in the PICU, comparing attentional failures, which is like you took too long altogether to tap the screen, you just missed the deadline, or overall reaction time. And the upside down triangles, the unfilled triangles are scheduled with shifts greater than 16 hours, and the filled in upright triangles are shorter shifts. And what you see is firstly, a big difference between, and a statistically significant difference between the people working longer shifts and shorter shifts, more attentional failures and slower reaction time. And the other thing is over the 4 weeks, regardless of which schedule you're on, working in the PICU is hard, right? And people don't sleep as much as they do when they're on what's coming up as a Y rotation or a Y prime rotation, these lower intensity rotations. I don't want to single out the PICU, the ICN, the hospital medicine service. But again, the idea is working shorter shifts still is hard, but it's not as rough on the body as working those prolonged shifts, the 24-hour shifts and such. The other thing, people always make this comment about sleep deprivation and being drunk. So there actually is data. This is from a Nature paper from '97 that kind of looked at this. And what these researchers did is figured out people's mean relative performance and standardized that to 1.0. That's your own performance on these psychometric tests averaged over time. And then sort of plotted it out by hours of wakefulness and see that it's about 16 hours is the point where our own performance goes below our own average. And for those who remember the first round of duty hours, right, when interns were limited to 16 hours, and that's why all of these studies use 16 hours as the break point, because that's the point from this study that was kind of shown, that's where our own performance goes below our own average. So then just to also compare this to the alcohol, so 0.02, 0.03, that's one-ish drink, you're still maintaining about your average performance, but 24 hours of wakefulness gets you at about sort of is when your performance is dropping to the low 90s. And that's also around where you're getting to the legal limit of being drunk. And so that's where that comparison of saying your performance when you've been awake for 24 hours is at about the performance of being at the legal limit for alcohol consumption. So it's not totally made up. That 16 hours that the ACGME put out, it wasn't just created out of thin air. It was evidence-based. The other thing, this is one of my favorite studies. This is out of Stanford, looking at anesthesia residents and just asking this question, do we even know when we're sleepy? And so the researchers in the study did what's called a sleep latency test, where they put people in a dark room and just say, just sit there, don't go to sleep, just sit there. And they monitor them with EEGs. And they have two objective outcome measures from the study. One is, did they fall asleep as measured by EEG? And the other is asking them, did you fall asleep? So like, did you know that you fell asleep? And any guesses as to how right or wrong people are? Think about it for a sec. So residents were wrong 76% of the time when they thought they stayed awake. So again, they were asked, did you stay awake? 76% of the time they thought they were awake the whole time during this study. And in fact, the EEG showed that they had fallen asleep, right? And it happens to be that the study population is residents, right? That this happens to all of us. This is a human thing. We don't know that when we're super sleepy. I also want to acknowledge that sleep and work exist in a broader context, and it's really important to think about this. So firstly, people have relationships, they have families that are impacting their sleep. And again, people have differential impact depending on the age of children, whether or not you have children in your home, what the needs of those children are, adult family members who may be staying with you or may have other responsibilities. Some of you know, for a large number of years, I was helping support a family member who had a chronic illness on the East Coast. And my phone never went off. And I got woken up pretty frequently with issues that would come up because it would be 8 a.m. on the East Coast and I was getting called. There are socioeconomic factors that come into play that also put differential impact on individuals. So thinking about the relationship between income and sleep. So people who have more money have more freedom to live closer to the hospital where it may be more expensive here in the city of San Francisco, right? It's hard to buy a house in San Francisco. So there may be a differential impact on people who may be lower income, have to live further from the hospital, and therefore have to wake up earlier in the morning to commute in and be at work at the exact same time, or relying on BART to get here at exactly the same time. There's also for people who moonlight, right? People who may be lower income may be moonlighting more, or people who have more medical school and college debt, right? May be moonlighting more. And so even though they're working the same schedule, they feel this pressure to take extra shifts, and that impacts their sleep overall. Individual lived experiences show up in a variety of ways. I want to acknowledge that there are data that individuals who experience more discrimination and who experience more racism have lower quality sleep. And this applies to both overt and subtle discrimination, as well as racism-related vigilance, which is the idea of like being ready to experience racism when you show up to work, or discrimination in some other way. All of that, there's good data that all of that actually really does impact sleep. Personal health issues certainly come into play. And so all of these may contribute to sleep deprivation in different ways. And so I think it's important to think about that not every schedule has an equal impact on every person, right? And creating grace when people ask for extra time or extra space, and recognizing, as I think our leaders in our department are extremely respectful of thinking about individual needs with respect to scheduling and work hours. Effects on language, we make more mistakes with complex language tasks when we're sleep deprived. So complex tasks like listening to a person speak to you for 3 to 5 minutes straight in a language that's not your native language, that's going to experience more errors. I'm bilingually certified to provide care in Spanish. I know that when I'm sleep deprived, my Spanish comprehension is not as good. And so I'm just getting the interpreter there. I also know that a simple task like walking in to ask a question about one symptom is going to be much easier than taking a history and physical, where you really need that sustained vigilance, right? And so this sleep deprivation may have our sleep deprivation may have a disproportionate impact on patients who speak languages other than English. And things we can do include increasing vigilance, more attentiveness when we're using non-native languages, meaning languages that we are not native speakers in. And of course, using interpreters, right? The sort of golden rule of interpreters being, if you would want your own care in English in the state that you're in, then you probably deserve an interpreter for your patient, right? If you don't speak their language well enough that you would want to receive your own care in that language, then you probably need to be using an interpreter. I would say definitely need to be using an interpreter. And some sleep impact on medical errors. I should say, this is not sleep impact, this is schedule impact. And this is like the first study out of Boston Children's that really brought attention to this in residents and fellows. So looking at medical interns, so medicine interns working Q3 call. This used to be a thing. It's not very common anymore to do Q3 call. Max length 34 hours, averaging about 80 hours a week in the hospital. Comparing them to medicine interns working shift schedules with a max length of 16 hours and substantially fewer hours. No changes to the supervisor schedules, but some handoffs improvements. And the finding of serious medical errors dropping significantly in the intervention schedule. And in particular, those preventable adverse events dropping, though not statistically significant, probably a power issue. And I think the interesting one is diagnostic errors. And Julia Adler-Milstein in the Department of Medicine is doing more work, right? They just set up this Center for Diagnostic Excellence at UCSF. There's a lot more work to try to understand how diagnostic errors are showing up in our work. Probably an interesting area where we're going to see more AI utilization, stuff like that. But one of the things I like to point out about this study is over time, what we've learned is the bigger impact is probably in the total number of hours worked per week as we think about schedules, because just reshuffling, if you just reshuffle to shift length without changing the total hours per week over time, you don't get the same effects. And I'll talk a little bit about that. And then just to say the surgeons, there used to be this lore, we have procedural memory from muscle memory. And when you look at surgeons doing a task trainer in the sim lab, and comparing people who were in a control group compared to people who were like, it was a sham call where they would sleep at home, but they would get woken up several times throughout the night, so interrupted sleep, compared to people who are kept awake in the sleep lab. The less sleep you get, the more errors you make, and the more time it takes to complete a task. Right? I don't know if anyone here is a surgeon, but certainly people do procedures that we practice in the sim lab. And I want to acknowledge there's another side to this. Right? I would be remiss if only I showed the data that it's all negative impact on patient safety. Some of you know the first study and the iCompare study. These were studies first was in surgery trainees, and iCompare was in medicine trainees. And basically what was done in these studies is comparing residents working under duty hours that limited the interns to 16 hours. This was the first round of duty hour limitations. Seniors could still work 24 plus 4 as long as they had a break, and compared that to residents working under flexible duty hour guidelines, which at the time flexible meant that anyone could work 24 plus 4. So 24 plus 4 refers to 24 hours of direct patient care plus another 4 hours to transition care, maybe by rounding, but you couldn't take new admissions. And the bottom line, oh, I forgot about the animations. Overall, in these studies, there was no difference in outcome measures, but the outcome measures in these studies were 30-day mortality or serious complications after an operation, take-backs to the ORs, ICU transfers, things like that, and some very high-level safety measures. So these studies were these were large multi-institution studies that relied on Medicare databases and the NSQIP, the National Surgical QI Program, to get their data, as differentiated from the studies I showed you before from the Boston Children's data, which was actually looking at charts, as we've done in the IPASS studies, actually looking for medical errors more actively. And so, I just want to share this as an aside. There's no data that more handoffs led to more errors in these studies. That's always something that comes up. If you shorten shifts, we have more handoffs, and that's going to create more errors. Well, if that were the case, then these studies would have found a difference, right? The shorter shifts with more handoffs would have been worse, but there was actually equivalence. That said, again, I don't like these studies anyway, because I don't think they're sensitive enough to find the kinds of things we're looking at. So my interpretation of the data in context is that large studies using large data sets have not identified a significant increase in major harms. And I think that's fair, but the harms they're looking at are readmissions, OR takebacks, deaths. You'd have to have really poorly supervised trainees. Rio Hiroshi, sort of, when he looked at some of you know Rio, he's a transplant surgeon, used to be a transplant surgeon here. He sort of said, if you could find any surgical impact from duty hours being changed, that would be a gross failure of supervision on the part of the faculty. Smaller studies using chart review have identified a significant increase in minor harms. So harmful medical errors, so diagnostic errors. And when I think about those, just to know, when we do medical error studies, if a patient has an unnecessary blood draw, that is a harm. Right? For those parents in the room, if you have to sit there while your 2-year-old is getting an unnecessary blood draw because we talked on rounds about adding in the electrolytes to the CBC and I was sleep deprived and I forgot to put in that order and the patient needs a second blood draw, we consider that a harm because a patient experiences unnecessary pain, right? That's not going to show up in readmissions or takebacks, deaths. Similarly, if I misdose the vancomycin and a patient has a creatinine bump, that's a harm. The kidney experienced harm. As a result of that, it's not going to show up in any of these kinds of measures. So when we think about what we would expect to find with sleep deprivation, right, I think we need to be looking a lot more sensitively. And that's why I sort of make this comparison between the two studies. So that said, when I think about the weight of the evidence, I would definitely say it's sort of skewed. There is greater, heavier evidence to say that shorter shifts and fewer hours per week are better for patients and better for us as providers. I don't think it's totally one way, but I definitely don't think it's like an even split. There is not equal data there are not equal data on both sides. Some of you appreciated the grammar. I want to acknowledge that we also risk hurting ourselves when we're sleepy. So there's good evidence that we have higher odds of car crashes, higher odds of near miss accidents, higher odds of needle sticks. These are large studies of residents completing surveys. Did this happen to you last month? So these data are from almost 20 years ago now. I'll show you in a moment newer data that are just the same. And again, thinking back to that anesthesia study, we may not know when we're too sleepy, right? So we may be doing a blood draw and actually not realize that we're too sleepy to do it well, or doing an operation or doing sutures, or again, driving home. And we'll come back to that, some suggestions and best practices. So these data are from just last year. And this is a national study, again, Laura Barger at Boston, and this is out of a larger study that they recently did. And just to orient you, so the left side is working 90 hours per week. So there are people who still were reporting working 90 or more hours per week. And each of these lines represents a different kind of potential harm that were reported by residents in these monthly surveys of, did this happen to you? Car crashes, near miss crashes, attentional failures, medical errors, and adverse events. So an adverse event being a medical error that harms a patient. And the thing just to draw your attention to is, the fewer hours you work, the lower odds of one of these harms happening. So it really has sort of a cumulative effect. The more hours you work, the worse it probably is overall, both for our own health and for those of our patients. And I do want to make the point, this is not just residents. This is a study out of Stanford from a couple years ago. It's a cross-sectional study of attendings and residents. About 2/3 were attendings, about 1/3 were residents. Looking at on the y-axis is respondents that indicated that they made a medical error that resulted in patient harm. And so there's sort of the baseline, people who were, this study also included burnout, but included burnout, sleep-related impairment, and sleep-related impairment with burnout. And just making the point that sleep-related impairment actually is more impactful than burnout, but they also compound each other. And again, making the point that it's not just trainees, it's also attendings that are making errors and are impacted by sleep deprivation. I think it's kind of been unfair and disingenuous to talk about it as a trainee or an ACGME problem. So I want to pause and just acknowledge that nobody wants this. This is the hard part, like putting out this data and say, this isn't fair. You're kind of saying all this and we don't have a choice. Because it is really hard to work in this system. And it's a difficult cycle to break. I like this graph from the Stanford paper, from Mickey Chockel's paper, of this hard sort of two-way problem, or bidirectional problem of long work hours leading to sleep-related impairment, leading to decreased performance, but also long work hours leading to decreased performance, which, if one's making mistakes at work or not feeling like they're doing their best by their patient, I'm not at my best, is going to lead to stress and burnout and sleep-related impairment. And then when we're not getting enough sleep, it takes longer to get the work done, right? If you're not awake, like trying to do an admission when you're drowsy is very different than trying to do an admission when you're at your best. So it's a really, really difficult cycle to break. And there's not, right? It's complicated because we have this issue that, yeah, sleep leads to better well-being, leads to better safety. But if we think about how do we change our shifts, shorter shifts may mean more shifts, right? So if you no longer take 30-hour shifts, then in order to work those 30 hours, you need 3 10-hour shifts. And that leads to fewer days off. And that may lead to decreased well-being, which may lead to decreased safety, right? So it's a complicated thing if we try to reshuffle within the same system. So part of what I'm going to talk about as we get into solutions is that we may need to break the system, right? The US system, and some of you, it's very financially driven, right? Because Medicare pays for resident and fellow positions. Doctors in private practice, for the most part, are not salaried. The more surgical cases you do, or the more RVUs you generate, the more money you make if you work in private practice. So there's almost an incentive to not go to sleep, to not take a break when you're tired. So it's challenging. I just want to hit on a few other things along these lines. So as we've said, like the duty hour / safety correlation is not perfect. The most convincing studies are the ones in which the total numbers of hours are limited. So taking people from 80 hours a week down to 60 hours a week. That's where you get the biggest bang for your buck in terms of general wellness and impacts on patient safety. We also can't force people to sleep. I asked a bunch of people about this. I spoke to some neonatologists and intensivists just in anticipation of giving, and I said, do you guys still like work those 34-hour shifts? Do you still take call while you're during a week of service? Most people have moved away from taking call during their weeks of service, but almost everyone said, I still have like a full day of meetings after I do call. So I do a full day of work and then I work my call shift and then I have a full day of meetings. So Zoom has kind of broken that, right? There was a time where people would just go home after their call shifts. Sandrine shaking her head. Sandrine didn't go home. But I think there was a model by which somebody who worked a night shift would say, I'm going home. And if you went home to sleep for a few hours, you weren't going to come back to campus for a meeting. But now people say, I'll go home. Let me just sleep for 4 hours and then I'll join that meeting. Inter-individual differences do exist. Some people need more sleep than others. We could have a whole conversation about whether we should like do attentional tests mid-shift to decide if you're like awake enough to do that next admission, what that looks like. What I just want to acknowledge is like that's a very complicated system with a lot of bias built into it. And again, there are financial incentives to pretend you're awake. Continuity of care always comes up as a problem. There are things you miss when you're awake for 24 hours, or things you see. You only see the first 24 hours of a neonate's life if you're awake, right? And you're there for that shift, or the first 24 hours of a kid with hypoplastic left heart. That said, my sort of counter to that argument is there's also benefit to working 6 days in a row and seeing every step of that child. So if you work the first 24 hours, then you're leaving for the next 24 hours. So you're still missing something. So it's sort of, how do you put those pieces together? Volume of experiences for learning comes up. If people work fewer hours, they see fewer cases, right? We have decided that there's a fixed amount of time. If we move to competency-based time variable training, then we can sort of take this argument off the table and say, maybe everyone doesn't have to work these crazy hours, and maybe people adjust by working more months on service or something like that to achieve the competency they need. And then, as I mentioned, the financial drivers are real, both at the individual level, people out in practice who need their RVUs, at the institution level, right? When we go to the chair and the chair goes to the health system and says, we need money because people are working fewer hours. And at the sort of health system level, this system is the US healthcare system level, right? And when the National Academy of Sciences, or the Institute of Medicine rather, put out their first recommendations a decade and a half ago, they said, we can't implement these unless someone's willing to pay for it. So that all said, I would say confidently, we don't perform as well when we don't sleep. Our patients probably experience more errors when we don't sleep. Our own well-being suffers. Duty hour restrictions alone are not the answer unless we limit total hours. So now I'm going to transition a little bit to what we can do about this. There are real strategies to mitigate fatigue. And the first one I'd just like to mention is awareness that we're all human, right? There are physiologic limits, right? When people, and we also need to give each other grace, right? When we are tired and say, I acknowledge you need sleep. And so I'll talk a little bit about optimizing, prioritizing, and asking for help. So speaking up for patient safety, I don't know if Deb's watching somewhere, speak up for patient safety. So being aware of sleep deprivation, right? It's often hard to recognize in ourselves, as that anesthesia study kind of showed, but speaking up when you need sleep, the ACGME actually requires that we have a process to transition care when fatigued. What I can tell you, and this is mostly directed at the faculty, the UCSF average is 91% compliant with this metric. In our department, there's a range. Some programs are 100% resident fellow reported compliance. Other programs are as low as the 70s with compliance. Everyone should be 100% compliant with a process to transition care when fatigued. asking people if they need sleep, right? Especially if you're a supervisor, asking your intern, like, right, do you need to go lie down for a little bit? And frankly, as a supervisor, a senior, telling your intern, I need to go lie down for 45 minutes and I'll be back. I'll talk about strategic napping in a second, but it's okay to take turns. And then kind of being willing to question the way we do things. So pilots are limited to 8 to 9 hours of flying time. Emergency residents have different limits. Do you guys know this? That emergency medicine, the emergency medicine RC, when they're rotating with us, they have to follow our duty hours, which is up to 80 hours. When emergency medicine residents are on an emergency medicine block, they're limited to 60 hours per week. They've decided as a review committee that they're going to limit their people. There are other ways to do things. Purposeful scheduling. UCSF was kind of a leader in eliminating extended duty shifts. This is the only slide where I'm mentioning my own research, right? We did some stuff looking at it early on, what happened when we went from Q4 call to day-night teams. And what we found on the hospitalist service on 6 Long back at Parnassus was length of stay and cost went down and ordering patterns shifted. We placed more orders to advance care earlier in the hospitalization. So the idea that a patient maybe who got admitted with gastroenteritis in the call model, maybe someone didn't advance their diet overnight. Maybe someone didn't try to wean the IV fluids. Whereas when we're just working night shifts, we're maybe more actively managing those patients, advancing diets, weaning respiratory treatments, things like that. So we sort of have been a leader in this. Strategic naps probably do matter, but if you're going to nap, take advantage of those circadian rhythms. So the best time to nap is when you hit that nadir at like 2 to 5 in the morning, when you're like, I just can't stay up. So trade off with your senior, right? And say, I'm going to go lie down and I'm going to set my alarm. And during the afternoon, if you're post call, the afternoon is the best time to nap, right? Napping from 9 to 11 in the morning is not as restful as napping from 2 to 4 or 3 to 5 in the afternoon. And always being aware of sleep inertia. So when you're holding the delivery pager is probably not the time to take a nap from 2 to 4 in the morning, unless your fellow or your attending is available to hold it, because you're not going to sort of wake up right away. When you're doing a stretch of nights, try to get adequate sleep between shifts. This is a big reason why the ACGME tried to limit night shifts to 3 to 4 in a row rather than 6 to 7 in a row, because we don't sleep enough during the day when we work night shifts. We just don't get as much sleep and it's not as restful. In some of the studies, what they've sort of done is staggering shifts so that you sort of work a typical shift and then maybe your late shift where you're working from 8 until 10 at night, and then you work your night shift and then you have a full day off and then you go back to days. So if you're switching between days and nights, there actually is purposeful data to sort of show, or sorry, good data to show how to do this purposefully. And then I just want to say, like, we can consider alternative models and break the system altogether. European countries do things differently, right? These countries all have different number of years of residency, and residents have different max limits. Now we can have the whole conversation about their entire system is different with respect to university, graduate school, length of time, cost. And I guess I'm just saying we can change our system, right? It would take some heroic efforts, but it can be changed. This is what they do in England. I don't think anyone thinks British doctors are poorly trained. Max shift length, 13 hours. Rest time between prolonged shifts. Sorry, this is during shifts. You're required to get a couple of 30-minute breaks during your shifts. Max night shifts is 4 per week. And then this one, I think is crazy, right? So the max weekly work hours are 48 hours, and you can get an exception to work up to 56 hours and 5 consecutive shifts. Right? The European system is just very different. It has very different drivers. And then pilots, right? We always talk about pilots and rest. Their maximum time varies based on their start time, their sleep opportunities, the number of pilots. So this is like the FAA guidelines of this is not how long they can fly, but this is their total duty period from when the time they have to report at the airport to the time they're dismissed from their shift. But what I want to point out is it's a different number of hours, whether your shift starts in the middle of the night versus whether it's a day shift. because people are naturally more awake on day shift and able to stay awake longer. It also changes based on the number of pilots on the flight. And class 1, 2, 3 rest facilities refers to whether you're given a flat bed to lie down on versus whether you're just sitting in an airplane seat reclining at 40 degrees and trying to take a nap. Right. So there are sort of purposeful ways to think about scheduling. Sleep, overall sleep management and mitigation. So the best sleep environment is dark, cool, and quiet, and using the bedroom primarily for sleep and adult activities, but not considering work an adult activity, right? So COVID kind of broke that, and people turned their bedrooms into offices. I know people were charting in their beds even before COVID, but I think it's important to remember that, like, prior to 2020, Zoom meetings were not the norm, right? They were an option for many meetings, but Zoom meetings weren't the norm. Now everyone I shouldn't say everyone, many people have their laptops in their room, right? And are doing work in their bed. It's just not great for sleep hygiene. Treating sleep disorders, if you have them, I found out in the last year that I have obstructive sleep apnea. I don't fit the profile at all, right? When you think about risk factors for obstructive sleep apnea. And I had an otolaryngologist say, like, you're kidding me, right? I got a sleep study. I found out that I have obstructive sleep apnea. Minimizing alcohol, because it results in lighter, less restorative sleep. It does put you to sleep, but it's not as good. Exercising is good. Exercising, actually, in the evening, exercise makes you more tired. In general, that physical activity, regardless of the time of day, is better for sleep. And then sleeping before and after call, setting a sleep schedule, using the do not disturb on your phone if it's at all possible. Recognizing that some people are just always on call and always have to be available. And again, in these days where everyone's calling you from your personal cell phones, we can no longer automatically just say, okay, anything from a 353 or 476 number can come through, but any other extension can't. You just sort of have to let everything through if you're on call in any way. But minimizing smartphone use at night, and if you're going to use it, blue light filters, and being aware that actually looking at the light may be helpful to wake you up if you're supposed to answer clinical questions in the middle of the night. Cues to inadequate sleep. I don't think I have to read all these out, but falling asleep in conference, I saw at least one person in the room doze off. I won't call you out. But I'm all for sleeping late on weekends and vacations. I think it's just an indication that you're not getting enough sleep at baseline. And then kind of burnout, apathy, there's pretty good association there. Caffeine works, Provigil works, but it doesn't solve the problem. It's like giving acetaminophen for fever. It'll make the symptoms temporarily go away, but it doesn't make the infection go away. It doesn't create sleep. And if you're thinking about using Provigil or modafinil, please talk to your doctor because it does have side effects. Just for interest, how much caffeine is in different products? Starbucks is far and away the strongest. What I like to draw attention to is that a Starbucks decaf still has about a third the caffeine of a Diet Coke, right? Folgers decaf, or the stuff they have in the break room for families in the family kitchen, that has no caffeine. But Starbucks decaf really is like a little methadone effect, right? It does hit the receptors. And I think it's just helpful to see. And then over-the-counter caffeine is 200 milligrams. So that's just where that fits into these. Driving while tired. You're too tired to drive if you have trouble focusing on the road. I know, thankfully, many residents don't drive, but many still do. And being aware of that, and certainly many faculty still drive to and from work. We have taxi vouchers at all sites for residents and fellows. Unfortunately, this doesn't apply to faculty, but for residents and fellows, we have taxi vouchers for you to get you home safely. If you must drive when you're post-call or tired, find a place to take a 20-minute nap, maybe drink a cup of coffee before going home. And if you have any of the signs of sleepiness, please, please, please pull over and take a short nap. Asking for help, and again, this is specifically aimed at the residents and fellows. If you feel like you're not getting enough sleep, if you feel like your schedule is not enabling you to do so, usually start with your program leadership. They know they have to be responsive. Chief residents, chief fellows are a great resource as well. But if that isn't possible, practical, or realistic, UCSF GME, we have a confidential hotline or helpline where you can leave a message. And then there's the safe reporting, which enables both anonymous or confidential reporting. So the safe reports are all reviewed by an ombudsperson in the GME office. I can tell you that person is not a pediatrician. That person is not in our department. Though several of us work in GME, it really is like de-identified. And you can even like put in like, I'm reporting for a friend who works in X fellowship and they don't feel comfortable reporting that, but you don't have to put any identifiers with the safe reporting. That said, the more identification you can provide, the easier it is to fix the system. I'm not going to go through our current policy beyond saying that our schedules, in order to protect hitting the 80-hour limit, we're limited to 72 hours scheduled so that we don't hit the 80. Our goal is for all of you to have a healthy, positive, and fulfilling training experience. So if we can help, I say this on behalf of all of the medical education leadership, all of the clinical leadership, basically on behalf of all of the faculty. If we can help, please reach out. And then for those who want the mini version, or if there's any program directors who feel like they want to like ping this out to their trainees from time to time, that's the 15-minute version from GME orientation. So if anyone's still, here, I can go back to that. If anyone's still awake, I'm happy to take any questions.
And, I'm not sure if there's any questions in the audience, but there's one on Zoom, and I think you touched upon
Anne has one
already.
I'll come back to you, Anne.
Oh, sorry.
I had a comment, which is that I think it's also important because trainees, like fellow and resident, often have some and they take home call. And I think a lot of times specialties across nursing, the fellows understanding that, and so I will just speak for myself. Fellowship, I get these messages at 2 in the morning that I think if the person had known that you were and on call from home, they don't know. And I think it's a lot of those little things actually quality of, like that, but I think added layer.
Yeah, thanks for sharing that, Anne. And I have one potential thing that may work for some people is on Volt, you can put in a custom message. And your custom message can say, home call, please message only for emergencies, or, you know, asleep, please message only for emergencies. And that's okay, because the message can go through if someone decides it's important. But I think that's totally reasonable for fellows, because as you say, right, some of our fellows are in the hospital taking calls all night, and they don't really care if they get an FYI notification, but others are like, I didn't really need that FYI until 7. Yeah, thanks. Sandraine?
But if I can add to that,
Please.
before I ask questions from the Zoom, I think in general, and this is not just about images, etc., but also when sending out emails or things like that, we all, and I'm guilty of it, we are like, I need to get this out right now, right? And I try to actually increasingly think to myself, but does this other person need to hear it right now? Does this, or if this person has an out of office on their email, then maybe I could put a delay on it, because they really don't want to see this right now, right? Do they need to be emailed on the weekend? Do they need to allocate this call right now? So it's sort of shifting your thinking about, now if you could get a system where you could do a delayed text, that would be awesome.
Right, text, yeah. But I love the delayed emails.
With that, this first question, I think you touched upon it a little bit, but do we have good research to show how many hours do we really need for full training? Is 3 years still enough training? Less hours per day?
Yeah, right. That's where we get into competency-based time variable training. If we really had a way to assess what it means to be well trained, then we could start to have those conversations. I think Duncan and others have really tried to explore how do we measure and how do we acknowledge individual variation. And it's really hard, right? Because there's a lot of reasons why time variable training is hard and unfair to some and biased in many ways, certainly the way we do our assessments and those determinations. But also, I think it's fair to reassess our fields, right? As we think about, you know, some of the upcoming training, or changes to pediatrics residency training, right? Some people may be better trained for inpatient experiences, and some people may be better trained for outpatient experiences, specialty versus primary care. We've decided that one pediatrics residency is right for both someone who's going to be an interventional cardiologist and a primary care provider. And we could change the first 3 years based on that. Oh, hi.
Hi, thank you for the great talk. A few thoughts. The first question is, do we have data about other healthcare providers, like nurses and other people who work in the healthcare, about sleep deprivation, or even just like their shifts in their work system?
Yeah, so there are some data on non-physician healthcare providers. One of the things I point out, just for what it's worth, is unionized professions tend to have better work hour limitations, but the human data really does sort of make a, it's widely applicable. So the performance metrics over time really are widely applicable. But yes, there are data for other healthcare professions that working longer hours is associated with more errors. What I do, since I saw some positive reaction to unionization in labor, again, it comes down to, we have to have the conversation. If you're working fewer hours, do you want to work an extra year to get that full level of training? And we need to be able to have that conversation.
And then the other question related to that, you can see that, for example, in nursing shifts, when they are on shifts, you will see that, oh, they are on break. And someone is taking care of the patients for them. We don't have this as trainees or even as physicians. And that could be one intervention where, until we change the system and think about longer training years, even shorter hours, could this be a smaller change where there is a culture of this person, this physician or an attorney is on a 30 minutes or 45 minutes break, maybe they can take a nap or get a rest. Just trying to, like, this Japanese culture of they actually take naps during work hours, and they have the facilities in their workplaces to take naps.
Yeah, so thanks for mentioning that. We don't historically have that culture. Nurses are better, but I do know a lot of senior residents who will tell their interns, like, I'm going to take your phone for a half hour on a night shift so you can, like, go have dinner or go lie down. And it could happen on day shifts as well, right? We could take each other's phones. And I say this to the attendings, there's nothing about being an attending that means you can't hold a resident or fellows bolt for an hour.
There's another question from the webinar. It's Dr. Lee Atkinson McAvoy. She says, wonderful presentation, Glenn. I wonder about the faculty experience for those who work overnight. What innovation needs to happen there?
Yeah, so I think some innovation, I appreciate the question. Some like behavioral shift has already happened. As I mentioned, when I asked several neonatologists and several intensivists about their call nights, it used to be that people did a lot of call nights during their weeks of service. Most people I spoke to said, I really don't do call nights during my weeks of service anymore. I do those nights separate so that the only time I'm really doing a 24 is on the weekends. And maybe it becomes a 24 plus a few hours because I work Saturday and then I have to round Sunday morning. There has been a shift away from it. But I think there does have to be a greater recognition. And again, when we think about RVU, productivity and other things, we have to balance health and safety against what we've said is a doctor's FTE, which is well above 40 hours, probably well above 60 hours, even at the faculty level.
Well, and can I just add, as someone who does night call, the academic productivity, right? Because that is what keeps us in meetings all day, the day after. And then the simpler things, can we not have fire drills in the middle of the night when we finally lie down for a couple of hours? And better mattresses in our call room, that would go really
I support the better mattresses in the call rooms.
Sometimes it's the little things, right?
But I also, with respect to your point about academic productivity, I think we really do, as a profession and as an institution, need to reassess what the denominator is and the expectation of showing up to meetings and being able to say, you know what, I worked last night, I'm actually not going to be at that meeting. And that's okay. And that's where I think, in particular, Zoom has broken things, where there's just, oh, sure, I could join. I'll listen on my car ride home as I'm trying to stay awake and focus on the road, but also, pay attention to this meeting.
I'll just give a quick European perspective, where I actually did a year of residency many, many years ago, but they initiated 48-hour work limitation just after I finished my year there, but never mind, no grudges. But what we actually had, without the 48-hour limits, we had 8-hour shifts. And so we did not have a call room. There was no call room. We didn't need a call room. Because when you were there for 8 hours, you were there for 8 hours. So there were 3 shifts a day, and we all loved it. But we did have a lounge.
You had a lounge. No call rooms, but you had a lounge. We can work on that.
Because the air was sleep deprived, but it's the same, so we had a beer once in a while.
But right, I think it's important to say out loud that with 48-hour per week limits, and some people do break that, but 48 hours a week and working 8-hour shifts, I don't think anybody questions whether Dutch doctors are well trained, right?
I get questions a lot, but
They
yeah.
have longer training years.
Yeah.
I did also a year of residency in the UK. They train for 6 to 8 years.
Yeah.
To become general pediatricians.
Yeah.
And that's where we have to have the tough question that's hard on so many levels, right? Do people want to extend training? If we're going to extend training, how much more do we have to pay people? How much more do we have to reduce medical school debt by if someone's going to take an extra year of training?
Without
It's-
that, and residents get paid much better.
Yeah. So these are all important conversations, but yeah, the finances really do come into play. It's not just about the hours and time, the money. Duncan, you want the final word?
I'm going to ask a hard question, which is, how do we change that conversation? Physicians have been having this kind of conversation for many years in many different contexts, and the ACDME makes their changes and
Yeah.
it gets pushed in different ways. And I'm curious, and I know it's a big question, so you could just like throw it back at me, but I'm curious about how we find somebody else and some other folks who are going to change it beyond ourselves. Because frankly, the institution of healthcare in the US is the thing that keeps us doing this.
Well,
So
yeah.
how do we either push back or how do we engage other parties in acknowledging that the system needs to be?
I'll give two answers. Firstly, I think it has to start with us, right? We have to be the ones to speak up. The first response is a sort of morbid answer, but I think there's something to it. Why do pilots allow themselves to be regulated? Because if a pilot makes a tragic error in an airplane, the pilot goes down with the plane. I think if doctors, I say this seriously, I think if every time I made a mistake at work, my creatinine bumped, or I had to get an extra blood draw, or I had to get an extra CT with contrast because it was ordered wrong the first time, I think I would be more careful. And I think I would be speaking up a lot more about not letting me work when I'm sleep deprived. So that leads to the more serious point is like, we need to make it about the patients, right? We need to find a way to take the focus off the sort of money and the hours and the rigor and this is the only way to do it, and really tell these stories about the data that shows a negative impact on patients. And we're starting to see more data on the negative impacts on the individuals. The reasons why UCSF was so aggressive about reducing to you can only be scheduled for 72 hours is because Dr. Lucy really said, like, we're not taking any chances. The data on well-being, the data on depression, the data on suicidality is so strong that we really need to take these extra steps to protect our trainees. So need to make the stories about our patients and about ourselves. And I think people will listen in a way that they sort of don't when they hear, oh, these rich doctors just want to work fewer hours. I think it really has to be about the patients.
I totally agree with you, Glenn, but I want to just add, if you think about the European examples, is that one of the biggest issues in the United States is that the way healthcare is funded and the way medical education is organized at every single level is not at all interconnected in any shape or form, right? Whereas if you have a uniform government that says we are actually the ones that are organizing both medical education and are funding healthcare, it becomes a very different story because then it has to be matched. I was just looking at all the match data across fellowships. We've added another 100 fellowship positions across all fellowships, even though the number of people who are applying to fellowships has stayed stagnant. And they were all moaning that we're not filling up our fellowships. And I'm like, oh, I'm surprised. Like, there is no national organization that actually has that overall accountability for training and financing and all of that stuff. And that makes this really hard, but it doesn't mean that we can't advocate for it. We need to say we need to start.
Yeah, and looking at the patient outcomes associated with it. right? The Kaiser model, where Kaiser owns the doctors, the hospitals, and the patients. If we had one person that owned the training, as you say, the training, the healthcare system, the whole process, the medical schools, the debt, right? It would be a whole different system. So Centrane's way is harder. Thanks, everyone. Really appreciate your time. Appreciate people staying with us.